Good morning. Welcome to the conclusion of the 22nd Northwest Patient Safety Conference. This session is How Patient Care Suffers When Money Comes First. Just to remind you, all presentations are being recorded. Presentation slides and speaker content information will be available on the conference website after the conference. Educational credit information will be sent to you after the conference. Please submit questions using the Q&A function. Tara will field questions after the presentation. I'm honored to represent Lifelight Network as a sponsor of this important patient safety conference. I'm Susan Gidding, Senior Advisor of Patient Safety at Lifelight Network, the largest not-for-profit air medical organization in the U.S., serving patients in the Pacific Northwest and Intermountain region. I'm attending this conference with several colleagues, and we are looking forward to sharing insights learned here today with our teams. I'll now introduce Tara Bano. Tara writes about the business of healthcare for STAT, a national health and medicine news outlet produced by the Boston Globe Media. Her beat includes hospitals, health insurers, doctors, private equity, and anywhere else that money and medicine intersect. She's been covering the healthcare industry for 12 years. Before STAT, Tara wrote for newspapers in Iowa and Oregon, and then at Modern Healthcare Magazine in Chicago. This year, she was on a team of reporters that won a George Polk Award, a Scripps Howard Journalism Award, and a National Headliner Award. There are massive amounts of money flowing into the healthcare industry, and for Tara, there's nothing more rewarding than helping readers understand where it's going and who's profiting. Please welcome Tara Bano.
Tara, before we begin, just a second, a little bit of housekeeping items. Everyone, the presentations are being recorded. Presentation slides and speaker contact information will be available on the conference website after the conference. Educational credit information will be sent to you after the conference. If you have questions, please submit them using the Q&A function at the bottom of the screen. This presentation will conclude with a Q&A. Thank you.
All right. Well, thank you so much for having me. I'm so excited to be here. It's been a wonderful conference. Let me share my slides, share my screen. All righty. Okay, so I'm very excited to be talking to you today. As Susan mentioned, I cover finance. I'm a business reporter. So I was thrilled when Steve asked me to do this, but also I was kind of like, well, what does money have to do with safety? And then I realized everything. So how much providers spend on staffing and training directly affects patient care. And I've written about this direct link many, many times. So at hospitals, salaries and benefits make up half of their expenses every year. So any changes to that spending flow directly to the bottom line. And maybe this has already been discussed, but a few days ago, the Joint Commission, that huge accrediting body that accredits over 22,000 hospitals and other healthcare providers, just announced that it's adding nurse staffing to one of the standards that it uses to accredit hospitals. It's never done that before, so I think that's actually a really important thing to note here. So first, I think it's good to get a lay of the land with respect to hospital ownership in the US. You know, how many are nonprofits versus for-profits? And I think it's important because, as I'll talk about, the financial incentives to either make a profit at any cost or it doesn't really matter, that really dictates how much of a priority safety and quality will be. So here is some data from the American Hospital Association. There are about 6,100 hospitals in the US. Of those, about half are nonprofits. So think, you know, Henry Ford Hospital, Mass General Hospital, Cedars-Sinai, Mayo Clinic. All of these big academic hospitals, those are all nonprofits. those huge systems like Ascension, Advocate, Sutter, Providence, those are all nonprofit. So 1,200 hospitals, 20% of them are for profit. And that includes the big investor-owned chains like HCA Healthcare, Tenant, and it also includes private equity-owned hospitals. There's also about 1,100 federal, state, and local government-owned hospitals, and then 650 for psychiatric hospitals. Many of those are run by two large publicly traded chains called Acadia Healthcare and Universal Health Services. I'm going to talk about those more in a little bit. And I want to just say, as an aside, I think this is useful for a lot of people, but if you ever want to know about the finances of a nonprofit health system, there's a website that I love to use, and they don't pay me to say this, but it's called DACBond. DACBOND.com. And you can just look up any nonprofit system on there, anyone that anyone that borrows municipal bonds, which is pretty much any nonprofit system. So the reason that I want to talk about the difference between nonprofit and for-profit hospitals is because there's a really different mentality in how they're going to spend money and what they're going to prioritize. So investor-owned companies like HCA, they have to report detailed financial results quarterly, and even, really tiny deviations from their profit expectations can just tank their stock. And I've seen this like on earnings calls, those analysts really just like drill down. If there's a 0.01% deviation from the profit projections, I mean, they drill them. They're like, I kind of feel bad for these guys sometimes. But I remember about a decade ago when I started listening to these hospital earnings calls, I was kind of shocked by the way that they talk about patient care. It sounds very crass, but it's super normal that in this world you talk about patient volumes, meaning the number of patients that are hospitalized, as a good thing. You want more of that. And actually, you want patients to be sicker. You want them to have higher acuity. And so I guess it's become very normal to hear this language, but I think at first it was really a shock to start hearing hospitals talk like this. And sometimes it just crosses this line where I'm like, okay, no, I have to write about this. I was listening to a Universal Health Services earnings call a few years ago, and the CFO said, we admit patients whose insurance pays us more. Kind of just flat out said that. And I guess it's sort of obvious that a for-profit hospital would do this, but I guess to hear it said in that way, I found kind of striking. So I ended up writing about it, and they were not happy. But basically, for-profit companies can take their operating profit and redistribute it to their shareholders, which includes their executives, people who own the company. So that in turn teaches people to buy more of their stock, and then the company becomes richer. So in a for-profit company, there is every incentive to generate the most profit possible. It goes directly back to you. And in that vein, you'll find that the spending is tracked much more closely. They want to cut costs at a much more intense level. And at these big nonprofit systems, obviously you don't want to be losing money, but it's okay to operate on a pretty thin or even negative margin. I would say the average is like 2% operating margins. In fact, it's funny, I would say that sometimes my colleagues and I, if we see a nonprofit system that's got like a 10% operating margin or a 15% operating margin in another industry that might be normal, but for nonprofit hospitals, I might look at them with a little side eye and say, that's a pretty high profit. Like, what are you doing to generate profit that's that high? And do you really need to be making that much profit in this industry? So I think it's important to raise this because the bottom line here is just that, subconsciously or consciously, profit, if it can't go directly to the executives, they're just less motivated to actually generate profit. 488 hospitals are private equity owned. My slides, I added a hyperlink to the private equity stakeholder project. They actually track the ownership of all the private equity owned hospitals in the country. So these are owners, companies like Apollo Global Management, Welsh Carson Anderson and Stowe. They're concentrated in rural areas. Texas has the most private equity owned hospitals, and New Mexico has the most per capita. A quarter of these are psychiatric hospitals. The thing about private equity is these are not companies that buy a business to own it for the long haul and like pass it down to subsequent generations. They typically want to resell the companies that they buy within 5 to 7 years, and they want to make double or triple what they paid for that company initially. A big reason why so many hospitals end up going bankrupt or closing after private equity buys them is the way that private equity structures these deals. So essentially, they do what's called the leveraged buyout model, which means that they take out a loan that's essentially secured by the hospital. So it means the hospital is responsible for paying the interest on that debt. They use the same financing model with really anything they buy. So cardiology practices, oncology, orthopedics, dermatology, it's the same kind of model. And so I've heard a lot of doctors and hospital operators say, financially we're breaking even, we're doing okay, but it's just that these extremely high debt payments make the financial situation untenable. And so that's where you see them actually going and declaring bankruptcy, and in some cases, closing. So I want to talk about, from a quality and safety and financial perspective, what happens at these hospitals after private equity takes over? What differences might people notice? There's actually quite a bit of research on this. I've written about all of the articles that you see here that came out, talked to these authors about their studies. This top left, the BMJ study from 2023, this is interesting because it was actually a systematic review of 55 studies of private equity buyouts in healthcare. It's the first widespread snapshot of all of the impacts of private equity investments in healthcare. The strongest effect that they found was higher costs to patients and health insurers. None of the studies found lower costs. The authors explained to me that they weren't surprised that cost was the most pronounced effect that they saw, because with these deals, the main goal is to drive up value. And the most direct way to do that is to charge more money. The impacts on quality and safety are sort of secondary to that. They're like a side effect of what they've done on the cost side, which is their primary focus. What they found was that 21 of the studies found a degradation to quality and safety in some way from private equity ownership. 12 of them actually found some form of benefit, which I thought was really interesting. But the authors concluded that on quality, the findings were sort of inconclusive, but there's a greater prevalence of studies that found harm. Another study found that when private equity takes over, they actually tend to employ more mid-level providers. So I'm talking about like physician assistants and nurse practitioners. These are providers who you can pay less because they have, they don't have to get as many years of training as an MD or a DO. This study wasn't able to say whether nurse practitioners or PAs have a difference in terms of their safety. And that's actually a pretty controversial question. Research has gone both ways on that. Just comparing the safety of mid-level providers to MDs. There was a National Bureau of Economic Research paper in 2023 that found the use of nurse practitioners in the VA increased hospitalizations by 20%. But other studies haven't found a difference. So it's kind of an open question. There was a JAMA study from 2023 that found complications spiked 25% after hospitals were bought by private equity. So that includes things like falls, bloodstream infections, surgical site infections, blood clots. And what was particularly interesting about this finding is that these increases in infections and falls happened even as the number of patients, the number of surgeries declined. So like, for example, surgical site infections doubled, but there was an 8% decrease in surgical volume. I mean, and of course, what is the metric we care about the most? Obviously, what's the worst outcome? Death. And we have research on private equity, very strong research linking private equity ownership in healthcare to more deaths. A lot of you might remember during the pandemic, this NBER study came out in 2021 that showed a 10% higher rate of death in private equity owned nursing homes compared to those that are not private equity owned. They found that that's because of declines in nurse staffing. There's less compliance with these national care standards, and there's just overall lower patient well-being. Meanwhile, the overall bill was 10% higher. So just think about that. You go to a private equity owned nursing home, your likelihood of dying there is 10% higher, and your bill is going to be 10% higher. I think that's pretty striking. Also, the Annals of Internal Medicine just last month came out with a study that found that deaths increased 13% at hospitals after private equity acquisitions, and that's because of changes to staffing and salaries. So the timing on this story that I just came out with was really fortuitous because, most of the studies I write about most of the stories I write are pretty focused on finance, on business topics. But this was a very big, I identified a very big safety problem in hospitals. And this is something I had been kind of researching for about a year. Of course, I kept getting sidetracked by other stories. But I'm glad that I was able to get this out before speaking with you all today. So essentially, what happened here was I was talking to a doctor in Florida who was sort of had a lot of complaints about his hospital, and he was saying a lot of talking about a lot of problems there that actually is very common, things I've heard about at a lot of different hospitals. But he said one thing that I hadn't heard before, which I thought was pretty fascinating and kind of alarming. He said that, essentially, we have a lot of patients here where they obviously have an infection, and we don't test them to find out what kind of infection that they have. We just throw some broad spectrum antibiotics on them and call it a day. He said the reason they do that is because they don't want to report those infections to the government. And I thought that sounded kind of wacky. I was like, that can't be happening. That just I don't believe that's happening. But then it kind of stuck with me, and I was like, wow, that is just really striking. I started talking to some of my other sources at other hospitals around the country, and they confirmed that this is really a trend. Like, there are a lot of hospitals out there doing this. So for context, since 2015, Medicare has slapped fines on the 1/4 of hospitals in the country that report the most hospital-acquired infections. So the 5 infections that are tracked under this program are C. diff, MRSA, surgical site infections, CLABSI, central line associated bloodstream infections, and CAUTI, catheter associated UTIs. So the fines are 1% of their Medicare revenue, which for some hospitals can be quite large. If you're a large hospital, it can be millions of dollars. If you're a small hospital, it can be a few $100,000. The overall penalties under this program have been $3.2 billion since 2015. But over time, they've actually generally gone down. So CMS is issuing fewer fines as the years go on. But the problem here I mean, as you can imagine, is that hospitals essentially have to tell on themselves to report these infections to the government. One of the professors I interviewed for this article, he said this is basically the worst pay-for-performance program that Medicare has because of the perverse incentives not to report infections. So here's how this happens. And I learned this from talking to about 25 different doctors, nurses, infectious disease experts. And basically, they said that some hospital administrators discourage doctors from ordering tests to identify which infections patients have. Obviously, if you don't test, you don't have to report those infections to the government. Um, these are not formal policies that you'll see on a bulletin board in a staff handbook. No way. They're not going to write this down on paper. But what happens is it's sort of informally communicated through staff members. So an administrator might kind of tell a nurse, make sure you tell the doctors to do this, or an administrator might communicate this to doctors directly. Doctors told me, they'd order a test through the EHR, and then they might get a phone call from the lab or from an administrator saying, "Are you sure you want to order this test?" And sort of trying to talk them out of it. One doctor said, a nurse turned to him and said, "Doctor, can't you just not order the test and treat the patient with broad spectrum?" And so, you can see how that nurse probably was influenced by an administrator saying, we don't want to send these tests in. Um, and I talked to doctors who had worked at these hospitals. They'd worked in healthcare for 20, 30 years. And they said it was pretty demoralizing because it felt like they didn't have as much autonomy to practice and to sort of intuitively try to understand patient symptoms and really make that decision about whether a test for an infection is appropriate. There's another element to this, and that is that not only do you have to test for the infections, but you have to send them to the CDC. The CDC tracks hospital-acquired infections in a database, and then Medicare pulls from that to issue the fines. So there's a type of healthcare worker called an infection preventionist. This probably isn't new information to you, but infection preventionists are typically nurses or epidemiologists, and those are the ones who take the test results and they review the patient's records, and then they determine, was this really a hospital-acquired infection? Because CDC has very strict, very specific criteria as to whether something actually qualifies as capital H hospital-acquired infection. So several of these people that I interviewed told me that they felt very intense pressure from their superiors not to classify these as hospital acquired and not to report them to the government. And they said it was really difficult to maintain their integrity and their sense of ethics and their sense of, no, I really do need to report this. It's the right thing to do. But they felt their jobs were at risk also. So while they said it didn't change how I behave and how I practice, I could see easily how in other cases it might persuade somebody to sweep these under the rug. One person told me that this situation was so stressful that she lost sleep. I think it's important to note that 7 of my sources who I talked to had worked at both for-profit HCA hospitals. Remember, HCA is this large system with about 180 hospitals. It's extremely profitable. They'd worked at both HCA and nonprofit hospitals, and they said that this gaming of the system, this suppression of infection reporting, was much more pronounced at HCA than at nonprofit hospitals. And that's not to say it doesn't happen at nonprofit hospitals, but it was just much more obvious. they said at the HCA hospitals. Now, I think Stats Lawyer would probably want me to say here that HCA did tell me that that's not true. They said that the company performs internal audits of infection reporting. They said it also uses a third-party auditor to then review that data and make sure that it's doing this all by the books. So with a situation like this, as you can imagine, because none of this, as I said, was written down, it's kind of hard to find a smoking gun. So when you're writing an article like this, I would love to have a document that explained exactly how this happened. But unfortunately, with this story, it was more about getting a critical mass of people to explain to me how this happens and to tell me with certainty that they know this happens. But I did get something that came pretty close to a smoking gun. A former HCA nurse shared an email with me that was from her boss, and it basically said, consider testing for C. diff earlier in the patient's hospitalization, because if you test earlier, then if they do have C. diff, then the hospital doesn't get blamed for it because we can say that infection came from the nursing home or wherever that patient came from. So this is happening at the same time as there is this movement toward reducing over testing and over treatment and overuse of antibiotic. And that is a real problem. I mean, there's this sort of widespread understanding that doctors like to kind of blanket the patient with blood cultures, stool cultures, and just kind of over test to be extra safe and be sure that you're tracking, you're getting every infection and treating it. But that does contribute to antibiotic resistance because we know that there's a ton of false positives with these blood, urine, and stool cultures. I found research that showed up to 60% of positive blood cultures can be false positives. And how that happens is just, you have a central line, or in the case of catheters, the urinary catheter, they just become contaminated with skin cells, something that was on the surface of where the catheter or the central line enters, and then there's a contaminant. And you test positive for an infection, but the patient isn't actually really sick. So it is, many people told me it is very important to only order these tests when you really suspect the patient has an infection. And doctors have been rightly criticized for ordering too many of these tests. However, I think it's important to say that all of the clinicians I interviewed about this, when I talked to them, I said, how do you know that what you saw at your hospital was not antibiotic stewardship? How do you know that they're just trying not to overtest people and overuse antibiotics? And they said, the reason I know is because in order for an infection to be hospital acquired or really considered hospital acquired, and you have to report it to the government, the patient has to have been hospitalized for 3 or 4 days, depending on the infection. If they're diagnosed with that infection prior to that time, it's not blamed on the hospital. So the clinicians I interviewed said, if I tried to order a test in the first few days of a patient's hospitalization, there were no barriers. I could go in the ER and order it, no problem. I didn't get a phone call from the lab or from an administrator. There was no issue. However, if it was after that point, and if it had been 3 or 4 days since the patient was admitted, then I would run into a lot of roadblocks. So yeah, you're probably wondering, like, what's the big deal? Like, a patient gets broad spectrum antibiotics anyway, like, who cares? Why is this a problem? Well, doctors told me that if they have to jump through a bunch of hoops before they can order any tests, it can delay the actual ordering of that test and thus the administration of antibiotics, because in some cases you can't actually start antibiotics until the culture is drawn, because the antibiotics could obviously, disrupt the accuracy of that culture. So when patients have infections, it's so important to start the antibiotics really quickly because those infections can very quickly develop into sepsis, which is obviously a deadly infection. So every minute counts. But also, several folks told me in the absence of testing, they're giving patients broad spectrum antibiotics instead of these more targeted antibiotics that would, that are less powerful, but more targeted toward the specific infections that these patients have. The problem with that is broad spectrum antibiotics disrupt patients' healthy gut bacteria. They can also make patients more vulnerable to C. diff and also antibiotic resistance bacteria. They're going to have probably a harder time the next time they get hospitalized, and they're gonna have to use more antibiotics, more likely to have to use broad spectrum. So these drugs can also harm patients' kidneys and liver. It's something that's very powerful, and you don't want to use it unless you absolutely have to. And it's important to note some patients have to be given broad spectrum antibiotics when they initially get to the hospital and before their test results come back to know what infection they have. But then the goal from there is always to narrow the antibiotics. Um, it was interesting after this story came out, I got a lot of feedback from different infection preventionists, nurses, doctors, and they basically said, I see this at my hospital. I see this at hospitals I worked at, and it's good that we're drawing attention to it. I even talked to a woman whose dad in his 80s, he was hospitalized for several days and he almost died of C. diff. They actually put him on life support. They couldn't figure out what infection he had. And then finally, they had him on life support. He was in palliative care. And then the one final doctor said, you know what? I think we need to test for C. diff. And sure enough, he had C. diff. And this woman, she can't say with certainty why there was no test for C. diff before that point. But she thinks it could very well have been that C. diff is a reportable infection. And they didn't want to test and didn't want to report that infection to the government. I think another important thing, sorry, I think another important thing to mention here is that what makes this so tricky is that one policy, the same policy that one clinician might interpret as antibiotic stewardship, another person might interpret as gaming the system. And so this happens in many, many cases, and it's really about the intention behind the policy that matters. So I'll give one example. I talked to a doctor at U Chicago Medicine, an infectious disease physician. She told me that her hospital screens all patients on admission for C. diff. And, someone who is skeptical of that policy could say, well, you're just trying to test everyone right away so that you can't get dinged for C. diff later on. But what this doctor said was no, we actually, if a patient is colonized with C. diff, meaning you have C. diff bacteria in your gut, but it's not making you sick. And this is actually very common with C. diff. Many patients are colonized. But she said those patients we separate from other patients. So we actually do take action based on this information from this broad screening that we do, and use that. But I think I did talk to others who were a little skeptical of screening all patients for C. diff, and they said that felt to them like gaming the system. But so just it's interesting to look at that one practice, and there's so much disagreement over whether that's the right or wrong thing to do. So I've done a lot of reporting on investor-owned psychiatric hospitals and the risks to patients and staff. So people who work in the behavioral health field probably know the names Acadia Healthcare and Universal Health Services. So these are the two biggest publicly traded psychiatric hospital chains. Both of them have settled lawsuits for hundreds of millions of dollars for patients who died or were assaulted under their care. Many of their former staffers that I've talked to say that their business model is basically to dangerously understaff the hospitals because, as I mentioned earlier, the staffing, it's the biggest line item expense that hospitals have. And if you can lower that, and especially if you're publicly traded like these companies, that's going to have a big impact on your bottom line. So that's all to say that in this industry, these are companies with some major baggage. Um, and just to kind of, not to belabor that point, but in 2020, UHS paid the government $122 million to resolve allegations that its hospitals admitted people that didn't need care and then held them longer than necessary until their insurance ran out. That lawsuit also accused UHS of understaffing its hospitals and undertraining its workers. And that's a big part of this because a lot of the folks that I've interviewed who worked at these hospitals said, we got really not a lot of training. The turnover was super high. The pay was not great. So in recent years, both Acadia and UHS have had these growth strategies of basically forming joint ventures with nonprofit health systems. So you'll see a new psychiatric hospital open, and like the photo here, it's got Mount Carmel on the front, or it'll say Geisinger or Tufts or Henry Ford. And it'd be hard to tell from the outside if that's an Acadia hospital or a UHS hospital. You'd probably think it's a Geisinger or a Henry Ford hospital. But in these deals, how they're structured is Acadia or UHS run the day-to-day operations of the hospitals. So they are the ones deciding how many nurses are staffed, how many technicians are staffed. They're deciding what the safety and training protocols are. The nonprofit systems typically are sending the psychiatrists to these hospitals. So they do have that interface. And then they also typically have people on the hospitals as board. But they're not really there overseeing the day-to-day operations. That is really left up to Acadia and UHS. On an earnings call a few years ago, there was an Acadia executive who described this joint venture strategy as the brand halo effect. That's a direct quote. So local nonprofit systems, I mean, they've got these good reputations. They're known in a community. They've done charitable giving. And you've got Acadia and UHS sort of trying to get under their own reputations. So they're kind of piggybacking off the goodwill that these other systems have garnered. So basically, I interviewed more than 50 former employees, patients, and industry experts for this piece who told me that they're concerned that these hospitals opening under these names of nonprofit systems are putting unsuspecting patients at risk. But I think, it's also important to note that if you're a patient who needs inpatient psychiatric care, in many communities, there's not a ton of good options. So even if you don't want to go to a hospital that's operated by UHS, you might not have another option. That is the reality in many situations. As far as why nonprofit health systems are striking these deals with companies like Acadia and UHS, they also don't have many options. It's a huge problem for nonprofit hospitals because when patients come into their emergency rooms in mental health crisis, it's a notoriously really unhelpful place for the patients to go. They end up sitting in a hospital bed for hours or days just waiting for a psychiatric bed to open up at a different hospital. So their conditions get worse. They often don't get treatment. Hospitals, meanwhile, that's a bed that's taken up by somebody who would be better treated elsewhere. And then they have less capacity to care for patients who come in with strokes or heart attacks. And it's really, not to be crass, but it's a financial problem for nonprofit hospitals as well because they're losing money on these patients coming in and using resources, but not actually getting really decent treatment. Um, so the biggest problem at UHS and Acadia hospitals, as I mentioned, is just bare bones staffing. Many of these patients are required by their doctors to have one-on-one treatment. You need a one-on-one staffer monitoring them at all times, and most of them, often I was told, don't get it. There's not, in many cases, one-on-one therapy. Even sometimes group therapy doesn't happen. Um, Fewer staff members watching means fewer staff members are able to intervene when something goes wrong. So people described patients, being assaulted, raped, even killed by other patients, or in some cases, the assault happens by employees. And it happens because there's just not enough people to have eyes on patients at all times and intervene if something goes wrong. Um, and of course, these are the highest acuity patients that there is. These are people who are here because they're a risk to themselves or other people. Um, I spoke with a nurse who worked at two UHS hospitals, and she said the formula was basically to understaff, but not only do that, then admit as many patients as possible. So she now works at a nonprofit hospital psychiatric unit and said that she's assigned to far fewer patients than she was at UHS, but now she actually has time to go and talk to her patients. She has time to notice if they're starting to look agitated, and she can see if they're pacing, and she has time to go and intervene before, something happens. Another former nurse who worked at a UHS hospital told me, quote, the staffing levels are just terrible, unsafe, and even if you're not staffed, they still pile on the admissions because you've got to make money. The image here is an excerpt from a letter that I found through a records request. It was written by a police sergeant in Columbus, Ohio, and he wrote to state regulators asking them to shut down the Acadia Psychiatric Hospital in that city because he feared patients were in danger, and he just had, he felt like he had nowhere else to go for recourse. So, along with this letter he sent the state regulators, he gave them a rundown of the 911 calls that had come from the hospital to his department. Um, he said they responded to more than 20 calls in 6 months. And so some of those included, rape, a patient was punched in the head, a nurse was attacked with a razor, a patient running onto the highway, a patient died. And again, this is a hospital that is named Mount Carmel. It's named after the local nonprofit health system. So if you didn't know, you would think this is Mount Carmel. This is not run by Acadia. Another one that I want to talk to is you've probably heard of HCA's acquisition of Mission Health in Asheville. So this was a case where I went to visit Asheville and talk to folks there to find out what kind of changes they were seeing after HCA took over, because I personally just hadn't seen that level of opposition to an acquisition. After HCA took over, it was really striking to see the amount of, doctors and patients and even state representatives who spoke out. Um, as I mentioned, HCA is the biggest hospital chain in the country, over $70 billion in annual revenue. Before this deal happened, Mission Health was a six hospital, well, still is a six hospital system, but it was a nonprofit system headquartered in Asheville. And basically, really well regarded, nationally recognized for its quality of care, very community oriented. A lot of the areas it serves are pretty rural, and you had patients in those rural areas, those small towns, getting really high quality care that was kind of unusual for a place, places with such small populations. You didn't see that. Um, I want to mention too just something about HCA because I've spent a lot of time talking to people about how they operate, and they are a really unique company just in terms of, well, they're sort of the stock market darlings of the hospital industry, I would say. Hospital industry analysts just love them. They constantly are just profitable and meeting their profit targets and exceeding them even in many cases. But first of all, when HCA buys hospitals, which I guess it's not doing a ton of anymore, but back when it was in its big acquisition days and growing to become the company that it is today, it really only buys hospitals that have dominant market share in their specific region. And I've spoken with people in multiple HCA markets who told me that once HCA takes over, the other strategy is to reduce staffing, particularly nurses, to save money. And it also charges very high prices. So you've got, they're squeezing on the expense side, and then they're also trying to generate revenue by charging a lot more money. When I wrote this article, the charges at HCA nationally were 9 times the cost of delivering care, and that's compared to a national average at the time of 3 times. I've also interviewed doctors who said that HCA has this strategy of trying to get as many patients through the doors into the hospital as possible, just because that's, the way they make money, and then also shortening their length of stay, just because, the longer a patient's in the hospital, actually, the less profitable that stay is going to be for the hospital. So what's so interesting about Mission and why I really just wanted to highlight this case for folks is that Mission itself was formed in 1995 through what's called a Certificate of Public Advantage. So Asheville's 2 hospitals basically wanted to merge, and they're 2 competing hospitals. Usually, the federal government would say, "No way, no way. That would be a monopoly in this region. You can't have the 2 hospitals in the same town merge." But so to get around that, state lawmakers can pass this Certificate of Public Advantage. It's a type of law that effectively allows the state to regulate a monopoly and put, guardrails on it to hopefully, alleviate some of the effects, the financial effects of having that monopoly. So it's sort of like a regulated monopoly. Obviously, before this deal closed in 2019, it was a big deal. It was very controversial. You had the FTC, very publicly coming out opposing the deal. There were some economists who opposed the deal. And so it did go through though, obviously. But in Mission's case, the North Carolina COPA law, it said, place limits on the amount of profit that Mission could make under HCA's ownership. It placed limits on the pricing, how much it could raise prices, and it also limited how many doctors that Mission can employ. So, and importantly, Mission could not be owned by a for-profit health system. So when Ron Paulus became CEO of Mission Health, he asked lawmakers, he said on day one as CEO, he asked lawmakers, scrap the COPA. We got to get rid of it. That finally happened 6 years later in 2016. HCA's offer to buy Mission Health came the following year in 2017. So you can see how this monopoly is formed, and then the minute that it is scrapped, HCA comes in and effectively purchases this monopoly that was, formed by the state and then preserved. So what changed after HCA took over Mission? The biggest change that people talked to me about was basically just that there were fewer nurses, there were fewer medical assistants, technicians, housekeepers, and that created a very unsafe environment, really unsafe conditions. I interviewed dozens of doctors and nurses and other clinicians, and they basically told me that a lot of these people were fired, but a lot of them also left voluntarily because it's sort of this domino effect. When you lose people and you are creating, an unsafe work environment, maybe the wages aren't as good, a lot of people are just leaving voluntarily. But they told me that, um, there were secretaries, support nurses, and discharge planners who were fired. Um, Eventually, a lot of the doctors left too because they also felt the conditions were unsafe. Over 200 doctors at this point have left since HCA took over in 2019. Um, the the staff departures even, bled down into the technicians who sterilize the medical devices between surgeries. So I went out and I interviewed a surgeon who said half of his surgeries some days were canceled because of this, because they didn't have enough sterile equipment. Something as simple as that you wouldn't think about. But that's the kind of lower paid worker who, could just as easily get a job at Amazon or McDonald's. And honestly, that job might be a lot easier than working at this hospital. Um, One thing that happened that was really striking is all five medical oncologists that HCA hired to staff this hospital actually quit. And I didn't know this before I started working on this, but medical oncologists are sort of like the primary care doctors of cancer. Like you might have a surgeon and a hematologist, or a specialist that focuses on the type of cancer you have. But medical oncologists are really important because they're the ones who give you the diagnosis and design your care plan. But all five of these medical oncologists that HCA hired to staff Mission Hospital in Asheville quit. The longest tenure was 3 years. The shortest one was 7 months. I talked to one of these doctors who quit and this person didn't want to be quoted or identified because obviously they're very scared of retribution from HCA. But the person said, I left because I couldn't, in good faith, take care of patients somewhere that I didn't think was safe. Safety is paramount, and it just wasn't a safe place to do it. What was even more striking was that the local oncology group that staffs Mission Hospital back in 2023, they stopped providing inpatient chemotherapy to patients at the hospital. I interviewed the medical oncologist who heads that group, and basically what he told me was that with inpatient chemotherapy, you have to wipe out the patient's immune system. So a simple infection or a fever could kill them within hours. So you need nurses to be regularly checking their vital signs and making sure everything is clean and safe. They basically said, we don't feel confident that that's happening at this hospital. He told me, quote, it was just a matter of time before something was going to slip through the cracks and someone was going to get hurt. Um, by the way, people who need inpatient chemotherapy, those are people with very complex blood cancers. And so now dozens of those patients are traveling hours away for treatment. And they typically have to stay in the hospital for about a month. So these might be situations where, their family members are probably staying quite a ways away to be with their family members for this care. Um, there was When I went there, there was a big community forum. And I know it wasn't the only one back in 2023, and more recently. They've just, you got people just pouring into these forums who are very passionate about the changes that are happening. And you've got people going up and speaking. So when I was there, these more than 120 local doctors delivered a letter to missions leadership, and they called HCA's changes devastating. And there's also been a lot of lawsuits. So, two of the cities in Mission's coverage area, Asheville, and then a city called Brevard, those cities have both sued HCA and their respective counties. They accused it of using its monopoly power to drive up costs. Those lawsuits actually recently settled for $1 million. Seems like a small amount of money, but the mayors of those cities said that they were happy with the settlement because they were able to secure some promises from HCA, like continuing to run a rural hospital in Brevard until 2032. There are a few other Mission HCA lawsuits that are ongoing, including a 2023 lawsuit from the state's attorney general. He accused HCA of degrading emergency care and cancer care. There's also a lawsuit from the county that Asheville is located in, and it's alleging ER understaffing at Mission Hospital. And it's saying that that led to millions in damages to the county's EMS services. I'm open to questions. I'd love to chat. But yeah, if any of this that's interesting to people, please email me. I'd love to talk more. I love story ideas, so please share them with me.
Tara, thank you so much for that very insightful presentation.
Yeah, I'm
Um,
gonna stop sharing.
we have some questions and comments. I'm going to read the first one. Have you looked at the lack of credible annual validation programs to ensure reliable accuracy of reporting by hospitals among all the mandatory state reporting programs for hospital-associated infections? Seems a deliberate result of federal agencies to exclude the American Society for Quality ISO standard methods for quality control.
Wow, that's really interesting. No, I haven't looked at that.
See, for example, Fortuna JA, you can get a copy of what's in the
Yeah.
chat, but there's some examples, and this is from David Birnbaum, who's actually on a conference planning committee.
Oh,
Next is a comment. Privately owned psychiatric hospitals sound as ominous as privately owned prisons.
yeah. Yeah.
Next comment, and it is a comment, and this is by someone who was a physician, also on a conference planning committee. This avoidance of doing culture/testing is both astounding and not surprising. For years, medical group contracts with health insurance companies have included withholds that get paid based on performance. While some performance evaluations look at specific clinical criteria, like number of patients who have received appropriate screening services, payment of the withholds is also based on the dollars spent on lab, radiology, and hospital admissions for the group's patients. The less money spent on labs, radiology, and hospital admissions, the more dollars paid to the medical group from the withholds.
Wow.
And question, have you ever checked out any Idaho hospitals in southeastern Idaho?
I have not, but I'm very curious what that's alluding to.
Perhaps this is an anonymous attendee, perhaps they can clarify. Next,
Yeah.
any data on which systems or hospitals are forced to absorb the patient populations when PE, private equity owned hospitals are dismantled or sold?
Yeah, that's a really good question. Um, I don't think there's good data on that actually. Um, it really depends on the location. But yeah, I guess I would imagine You know, in many cases, like you think about Texas, there's a lot of county hospital districts in rural areas. I would imagine some of them probably absorb a lot of those patients. Um, but yeah, I'm sorry. I guess I'd have to look at the specific um, region because I think a lot of that's probably dependent on where you are.
Next one's an interesting one. Is there a correlation between privately owned / nonprofit hospitals and red / blue states?
That is a really great question. Um, This is not scientific, but I do think there is a correlation. Yeah. You see a lot of, you know, like HCA, Tenant, these for-profit hospitals, they tend to be very concentrated in red states. So you do see them more in Texas and Florida. You see them more commonly in the South. Conversely, you know, think about like the East Coast. I think about, you know, New Hampshire, Maine. You don't see a lot of for-profit hospitals. Well, actually, HCA does recently have, it did have some hospitals in New Hampshire. One of the hospitals I studied for my infection story is an HCA hospital in New Hampshire. But I do think, for the most part, blue states tend to have more nonprofit hospitals. And I'm not sure, I would love to look into this. I've actually thought about this question a lot. You know, I'm not sure if it's just a factor of the regulations, of the types of laws that make it more conducive to running a for-profit versus a nonprofit hospital. I'm guessing that there are, you know, tax benefits that make for-profit operators more, you know, likely to want to locate in a place like Texas.
You know, this is it's a little bit connected to the next question. I had a personal experience at a mission healthcare facility. A very dear friend of mine, he passed away recently, but he spent months there, a couple of months, and it was just astounding to me because I'm one of his closest friends. I would spend hours with him at his bedside whenever he tried to call for help. On average, it would be at least 45 minutes to an hour when I wasn't around. When I was around, I'd have to actually go around, look for somebody. The nurse station would be half the time empty, nobody. And I would have to try and track somebody down. Usually it's somebody pushing carts of food, but no nurse, nobody that could actually help my friend. And so I feel that it really impacted his condition. And I do wonder if, you know, state legislations governing nurse-patient ratios come into play, given it's a hospital. So that's one question. But before you answer that, here's another one. In his keynote, Michael Millinson suggested we the people get loud and speak up. It sounds like the community in Asheville is doing that. So do you think it will make a difference to HCA's quality and safety decisions?
That's a great question. Um, Either way, you should speak up. Yes, obviously, definitely. Um, I think um, I think HCA has made changes and tried to be responsive to what's happened uh, in Asheville and in that region. You know, it's hard to say if they've really changed their staffing policies. Um, HCA is the kind of company that's big enough that they can absorb, you know, a less profitable region, or, you know, if people decide to go to a different hospital, that's not really going to hurt HCA. So they can take some hits publicity wise from this region that, you know, a lot of folks are really unhappy with the care that's being delivered. But I would never say don't speak up. I really think that all of the all of the um, legal challenges, all of the protests, they do make a difference. And one way they definitely make a difference is where hospitals in other regions are considering being purchased by HCA or being purchased by private equity. They see this happening and they make a decision about whether that's going to happen in their region.
Next is a comment, not to defend system gaming, but the infection reporting requirements were poorly constructed. This would encourage reporting fudging on some level, as there is a lot of gray between the black and white. A story on how these reporting rules were constructed might be interesting.
Yeah, I totally agree with that. Yes. I had a lot of people say like it is also a problem with the fact that there's a lot of gray area. And when you're the person who is looking at the patient's records and the infection culture results and trying to determine, does it actually meet the criteria? You could go both ways in some cases, and it's really a matter of interpretation. But infection preventionists told me that, ethics and integrity is really a big part of their job in determining whether an infection should be reported to the government.
Question: are all nonprofit hospitals created equal, or are there other loopholes that are exploited either by private investors or policymakers that make some nonprofits more successful, bracket profitable than others?
That's a complicated question, but yeah, I mean, I do think, you know, it's I don't know that it's so much that that a policymaker or a private investor um would intervene, but a lot of it is just by virtue of where you're located. Who is the patient population in your region? Is it a rural area? Is it a wealthier area where a lot of your patients will have commercial insurance? Like, honestly, that is kind of the financial that is going to affect your it's just sort of a product of your situation, of where you're located and who your patient population is. That is kind of the biggest factor that's going to influence your financial success as a hospital. But obviously there are these very prestigious academic hospitals that have large endowments and have relationships with funders and philanthropists that help them a lot. And there are struggling rural hospitals, county hospitals, that really are, trying to make a go of it financially, but don't have the same resources.
Absolutely. Question: is there a difference between for-profit and non-profit in terms of unions, represented nurses, etc.?
I have noticed a difference in terms of um, states. So I think some states tend to have a lot more unionized workers in the healthcare industry than others. But I would say it seems like, and this is not a scientific, I haven't done a real scientific analysis of this, but nonprofits do seem to be more likely to have unionized nurses and other workers than the for-profit companies. That's just kind of a unscientific observation, but that does seem to be the case at a lot of hospitals.
Comment: Joint Commission just announced a new national performance goal. Hospitals seeking accreditation must meet specific staffing standards. Trying to read it, there seems to be a typo. This is staffed to meet the needs of the patients served and staff component to provide safe quality care. It's a goal for 2026 probably to address these care gaps. Let's hope.
Yeah, and I agree. That's excellent. I mean, the Joint Commission has never before included staffing as one of its accreditation standards, and it seems so obvious. Like, of course, staffing is a big part, is maybe the biggest part of quality and safety. So it's really great that they made that change.
Right. So these have been really great questions and comments. We really appreciate your coming and spending time with us, sharing your expertise, sharing your experiences, your conversations with the people you interviewed, your insights. I hope everybody has enjoyed this presentation. I will pass this on to Steve Levy, who is the Executive Director of the Washington Patient Safety Coalition, to officially conclude our conference.
Thanks, Anita. Tara, I did have a question for you. So where do you think we're going in the next 3 years, given the current administration? I mean, are we going to become, going on a curve further downward, or do you think there's going to be some improvements?
Steve. That's a complicated question. Hospitals are in a tough place financially right now. I think especially with the changes coming down the pike on Medicaid, you're going to have a lot fewer people, potentially millions fewer people with Medicaid coverage. And for hospitals, that means a lot fewer paying customers. To me, I don't think that portends great things for safety and quality because when you're just in a more precarious place financially, you're less able to devote resources to staffing and these kinds of programs to make sure everything is safe, to make sure you're meeting all these quality standards, to get these certifications that you might otherwise get. I know I'm a little bit of a pessimist by nature, but it just seems like in a time when hospitals are potentially struggling more, that safety and quality could be at risk. But that's not to say that that it won't continue to be a priority for hospital leaders. It's kind of all a matter of where people put their intention.
Right. Well, thanks very much. That's a fantastic speech.
Thank
It's
you.
it's great to get your point of view on this because we're so, we're working in the trenches.
Yeah.
And it's nice to get an outsider's point of view. So thank you very much for doing this.
Thank you.
Yeah. Before everyone leaves, I just want to give a quick update on what's next. And this is important for all of us. If you were not able to log in well, or you're not getting correspondences from the conference, please email us. And let me put this up on the screen real quick. Email the coalition at Washington Patient Safety Coalition at qualityhealth.org and let me know if you were not getting any information from the conference. I want to thank our sponsors. This is the reason we were able to do this. I want to thank our conference committee. They're the ones who put this thing on. And then we also want to mention, we've got a lot of requests about this. The session recordings and slides will be available around the second week of November. And yes, CEs are available for the recorded sessions. We have many concurrent sessions, and you can add those on to apply for your CDs. And then the way you apply for your CEs is through the conference evaluation survey, which will be emailed to you next week. That's why it's important for you to make sure we have a good way of contacting you. 14 CEs for the professional certifications, and then 16.8 for nursing contact hours. So thank you all very much, and we will see you next year. Alina?
Hey, Steve.
Hey, did my slide show up or not?
It did, but it was like it wasn't in slideshow mode. But
Yeah, I know that. I know. I just want to
yeah,
get
yeah, but we could see it though. It was fine.
Okay, that sounds
All right.
good.
Bye.
All right. Hey, thanks.